I don't like fluid in electrolytes. I hate this study, this presentation. I've hated it since I was an intern because I just don't like it. It's painful. It's a lot of like science and stuff and not much cutting, so it gets a little boring. But it is one of the most important things we deal with, especially in critical illness and surgical pathology. So back in the day, Pear said that shock was caused by circulating toxins and treatment was phlebotomy. Well, they were almost there. And then Blaylock, you guys know who Blaylock is, right? If you don't know Blaylock, you need to go look him up. It's like the guy that saved all the blue babies from inventing a new way to suture in vascular anastomosis. And he said, hey, shock's caused by hypovolemic, so why don't we give him plasma replacement? And this guy Shires came out and said, well, it's that functional extracellular volume that's a problem. What we need to do is give crystalloid. And you know what? We're back all the way around again because we still don't know what's the most appropriate thing. We know that's bad. You should not give crystalloid to anybody if you can. Keep from doing it. We don't know what the best crystalloid is, so we just use normal saline because it's cheap. All right, so the distribution of the water in your body. Again, that goes along with what plants crave, with what you crave too. If you want to die quickly, don't drink any water. So what does the age have to do and the gender have to do with your total body water, Chief?
Higher males.
Why is that? Don't look at it. Women have higher fat, men have more muscle theoretically. That isn't always true. That's the gender, whatever reason for that. So we always have the adjustment to the equation so that we can account for that increased amount of fat, which causes less water retention. So when you're young, theoretically you're in better shape than you're old. And then also women continue to go up on their body fat instead of down, where men start to increase body fat later on in life. So what percentage of water, what is the percentage that we use? 60% for males, 50% for females. That makes a difference in the distribution of drugs that you give. It also tells you hydration status, how long it's going to take, how much fluid they've lost, etc. And then you can use it as a percentage. How many liters of blood do you have? I'll go 6. You can go 8. Maybe you live at high altitude. Okay. So if you see 6 liters of blood on the ground, they're probably dead. If you see 2 liters of blood on the ground, they're on their way to dying. And 3, you may not even get them back. All right, what are the compartments that we worry about when we talk about fluids and surgery? Go ahead, you can speak up like you mean it.
Intra and extracellular.
All right. So when we talk about the intracellular, we know where that's at. That's inside the vessels. That's where your blood is. That's where all those oncotic chemicals are that causes it to maintain intravascular pressure. Extracellular, that's the interstitial. And the, intravascular, sorry, intercellular, I had it backwards. It's early. My cup of coffee's not finished yet. But this is the one that we can really affect. Can affect this one too, but it's usually in a very pathologic manner. Okay, so total osmotic activity of a solution, that's the ability for that solution to pull water one way or the other. And the osmolarity is 0.9% for sodium. That's why when we're using for resuscitation or for head injuries, we prefer to use 3% to 7.5% saline so that we can pull more fluid in so it's more oncotically driving force. So this is 0.9, so you should know that. Everybody should have that in their back of their brain. And if you think about it, it's 154 milliequivalents. It's going to be an acidotic fluid. So if you give your patient this fluid, a bunch of it, you'll make them acidotic and hypokalemic. So normal osmolarity, this is where this thing comes in at. Let's see how osmoles for y'all. Well, let's see what the answer is, 280, 290. So if you have a head injury, you'll see us drive this up. I'll take it up to 350, or until the person dies or the brain herniates or whatever happens. Because at that point in time, you're trying to outweigh the injury to the brain. And the reason you drive up serum osmolarity is so that you can pull that fluid out of the brain, because the brain only has three components in it: skull, brain, blood, and cell, or CSF. So after all those things are taken care of, all you can do is dehydrate the brain. What's the difference between osmolarity and osmolality? This is the nerd stuff. If you'd asked me yesterday, I'd be like, it's just the same thing, it's just spelled differently. So osmolality is actually the osmotic force actually in water rather than ones in fluid. Duh, I don't know. Maybe that's a question somewhere. You guys are closer to medical school than I'll be ever again. How can you estimate it? I think I've seen this one in some sort of medicine textbook or something. It's like the George Washington manual to the intensive care or something. I don't know what you would use it for, but there you go. What are the primary electrolytes? It's what plants crave. What are the extracellular electrolytes, Pennington? Okay. What about intracellular? All right. Potassium bicarb, right? All right, so sodium chloride is the big thing that maintains your fluid status in your body. And if you remember that all shock states, sick states, whatever states, going to be, if you're trying to die, your body will do everything it can to hold on to sodium until it can't hold on anymore, and then it'll start wasting other things to do that. And so you'll have people that are hypernatremic and hypokalemic at the same time because it's dumping off the hydrogen, and they'll be acidotic or alkalotic. It does everything it can to save that. So if somebody says what's the most important molecule in your body, it's sodium. Your body will do everything in its power. And the reason for that is to maintain the intravascular volume so that when the saber-toothed tiger bit your leg off, you didn't die right away. All right. Where is water normally lost in the human body? Go ahead. Urine, GI, respiratory, here, sweat. How much is normally lost? That's a good question. Let's see. All right, so 1,500 out of the urine. Think about it. If you think about it, the size of a Coke can is 333 mils, so it's almost 5. What is it? Is it 550? What do you got, like those big Cokes? Okay. All right. Insensible loss, what does that mean? Skin and air. So you can't really measure it. We put you in the unit and we throw you on a ventilator, and then we start blowing air in and out of your lungs much faster. You don't have the natural humidification of your upper airway tract, then you're going to blow out a lot more. You could, because that always works. Stool, so about 2,400 milliliters a day is what you need to do to maintain equal. The majority of that you're going to get from your food that you eat. And what do? Well, we cause it. We can cause it here too, and we can cause it here. So if we give them a diuretic and we make them pee it all off, like mannitol, we give them C. diff, or if we put in an ostomy, you have a high output ostomy and they're dumping out of an ileostomy, that's the equivalent of it. And if you want to have a tremendous fight with the electrolyte imbalances, put a short proximal ostomy on somebody. And then fever, again, just call that anything you want. You put it as a acquired pneumonia, et cetera, et cetera. Okay, so the maintenance fluid. So in a non-stressed fasting state, 150 grams of glucose a day provides enough calories to limit proteolysis. Okay, so what's that mean? It says we're not going to start chewing on our own cells if we give you this much. Of course, we deal with all non-stressed in the fasting state patients every time they roll into the trauma bay, which is, if you're not catching the sarcasm there, it's completely false. Protein spare, the catabolic effect is going to happen. So you need to think about nutrition early. You also need to think about what you're going to do for fluid electrolyte replacement. What's the best way to replace any kind of electrolyte or fluid or food or anything else? Yes. You know, this is laser on the end of it. So generally it's oral, right? So everything we want to do is make sure that if we can get it orally, we will, instead of having to do IV. Daily requirements. Yeah, I guarantee you every American gets more than that. That's fine. Potassium, We probably don't get enough of that, but somehow we continue to stay alive. You know, all those fruits and vegetables you eat are going to contain that potassium for you. What's the ideal maintenance fluid for a non-stress fasting 70-kilogram man? Yep. See, that's what we always use. So we're trying to give them their potassium back. We don't want to give them a hypertonic saline, because even though it says it's not, it is. And then the D5 is to actually give them some food that goes with that. And theoretically, that should keep that patient fine. So what is the third space? We talk about third spacing in surgery. It's usually associated with postoperative course, and we tell you, hey, you need to watch this guy. He's going to third space the heck out of this fluid. What does that mean, Yoko? Well, it's usually your pleural effusions and your peritoneal cavity. I think some people get it confused with this as the third space. That I think we make the mistake of saying extravascular. It gets in the interstitial fluid, they get swollen and everything up. But technically that's still in that space of the extracellular space. But I always think about it as the third space too. And the pleural effusions are something that just happens when you're sick and you give them too much fluid. So you can lose a lot of fluid in this spaces right here. So if you think about pancreatitis as equivalent to a third-degree burn in the retroperitoneum, people forget that, and then they don't adequately resuscitate the patients, and then they die. So don't forget that if you have a burn or a big injury like that, you're going to take more fluid, and it's all about that leaking capillary bed. All right, GI losses, we'll go quick through this one. Why is this important? Savoy. Well, yeah, and you can definitely figure out where it's going to be. So if you have bile coming straight out, you're going to be losing potassium or sodium with it, a little bit of potassium, a lot of chloride, some bicarb. So you could expect them to become alkalotic maybe, or acidotic. You'd have to keep track of it. And where would you find this is any kind of ileostomy or anything that's proximal? Like the dude I have right now on the floor who's leaking bile out of his duodenal injury. Small bowel, again, what are the electrolytes you're going to have to replace? And large bowel. And that's why we keep track of it, because each one of these areas of your intestine absorbs something different. You know, what's the biggest job of the colon, Dr. Kim? What was that?
Reabsorb water.
Thank you. So it's a big deal. It holds a lot of that water that goes through as the stool gets formed. Okay, so what does it do? Sodium, why is it so important? They have these sodium, potassium, ATPase pumps, that live in your brain, all your nerve endings. Makes sense when you say that if you don't have them, you start to have a little bit of lethargy and all sorts of craziness. The regulation is antidiuretic hormone and aldosterone. So what happens if you get an aldosteronoma, Francesca?
Sorry. What's the question?
Oh, I don't know. Why don't you ask your buddy?
You lose all your sodium.
Do you think you have? Do you think you have hypertension with this or hypotension? Do you think you get a? Isn't that what's his? Didn't that's what JFK had? He had the golden tan from the pigmentation from it. And then the antidiuretic hormone is one that everybody's familiar with. If you drink anything that's an inhibitor of that, like alcohol or etc. Okay, so hyponatremia is low sodium. It's important to be able to deal with it. You got to know if it's normal, hyper, or a hypo. And then if you're in hypo, then is it hypovolemia or hypovolemia, euvolemia, or hypervolemia? All those are important because how you treat those are all separate. So what are the etiologies of these guys? Okay, so pseudohyponatremia, it's usually caused by something else, right? Something else is causing the sodium to be wasted in the face of this fluid bolus. And what do you think is one of the biggest causes of pseudohyponatremia? Yeah, hyperglycemia. So excuse me, I said that backwards. So what it does is your osmotic molecule of glucose actually retains fluid, dilutes out your sodium. You're really not that. See, I told you I hate this thing. I think I've read this chapter, I don't know, since 1996. I think I've read it every year. All right, so hyperlipidemia, hyperproteinemia, and that's for the normal osmolality. It makes sense because lipids aren't really oncotically active. Hyperglycemia, you'll see that when they're in DKA, and you're having to deal with that. All right. So what are the etiology of your hypo? So we cause a lot of it, diuretics. You can have somebody in the ICU who's got adrenal insufficiency. Non-renal is you're throwing it up, third space and burn, salt wasting. And then your euvolemia, your SIADH, and your psychogenic active, or your psychogenic polydipsia. Have you ever seen anybody like that? Now, I've never seen a psycho, but I've seen a renal form of it, and somebody who's on lithium, boxed her renals and her kidneys. She came in, they did a FemPop bypass. They didn't let her eat or drink, and so then she went into full-on. It was just horrible, trying to chase that back and forth because the kidneys weren't doing what they're supposed to do. Hypervolemia, CHF, our hated foe is liver failure. All right, cerebral salt wasting syndrome. Who wants to take a stash at that one? Albert? What does that mean? That's crazy. Is this real? No. You're in the unit, man. What you should do is ask Dr. Conrad today about cerebral salt wasting syndrome. See if he believes it. All right, so it's not a true injury to any of the organs that are involved. What we do is have an excessive sympathetic, causes your renal vascular hypertension and your dopamine release. And the circulating natriuretic factors that go with that. What it basically does, it looks like SIADH, except that it doesn't have the problems that you associate with it. You have to do other things. You can't really just fix it. Okay, and how do you distinguish against SIADH and cyclogenic polydipsia? That's somebody that's just going to be drinking too much water. Another one of those medicine things. Ew. So, if you are in the unit, Dr. Cox, and somebody dumps 300 of urine in like 3 consecutive hours of 300 or more, pretty white, and they had a little bit of a head bonk, what are you worried about? Yeah. So how do you fix it? Desmopressin, right? So if you see that in the unit, you see somebody who's got a head bonk, that's the first thing, a traumatic brain injury, and they are starting to dump urine, it could be that they're actually going into that, and it's usually a predeterminer of your herniation of your brain. Okay. What? Oh, that's true. Usually they're at that point. CHF and liver failure. Why do we have hepatorenal syndrome that goes along with it? All right, so again, you have to remember that somebody in end-stage cirrhosis has no real normal physiology left. They're having problems with shunting blood to distant organs. You're having your ammonia go up, and then you're trying to perfuse the hypoperfusion, so you're going to do renal venal constriction, then you're going to try to hold on to water, and it's just totally backwards. So then that's why you get ascites, because the ascites keeps leaking into your third space, and your kidneys keep holding on to more, and then eventually you're going to heart failure from it. Hyponatremia, what happens if you're hyponatremic? Oh God, get somebody say something like they mean it. Cerebral edema. Yeah. What do we see? Crazy. We go, oh, she fell down and hit her head. And we go, oh, it must be the head bonk. Well, no, let's find out why she fell. And let's go and dig down this and see if there's something else going on. We don't uncommonly see people who are hyponatremic that have head trauma. And there's usually some other underlying disorder we have to go dig through. They're able to talk to you, nausea, vomiting, weakness. The treatment, normal osmolar versus hyperosmolar. So normal osmolar, we don't do anything. The hyperosmolar, we give them what? We treat them for hyperglycemia. We put them on an insulin drip. We actively resuscitate them, put them on D50, and we just go ahead and start pounding this stuff in. All right, hypovolemic versus hypervolemic. Treat the problem. Stop doing what you're doing or figure out why they're doing it. So if they've got a bowel obstruction, take care of the bowel obstruction. It's kind of source control, right? You stop the diuretic, it's source control. So although we think we help people a lot of times, sometimes we actually cause them more injury than we did to actually lean forward and help them. Replacement with isotonic saline. All right. Treat the underlying cause of the CHF. Give a diuretic. Don't give sodium supplements. So it's kind of like if it's wet, make it dry. If it's dry, make it wet. There, you're now a dermatologist. Go on, live long and prosper. So if you're euvolemic, well, asymptomatic, just fluid restrict them. Put a loop diuretic on them if you need to. Try to get rid of some of that. Symptomatic, saline or normal or hypertonic, gold 130 milliequivalents, and you shouldn't increase more than 12 milliequivalents a day. Why is that? You gotta say it loud, say it proud. What does that mean? Yeah, you rupture those cells, things die, you get like your brain doesn't work anymore. It's kind of embarrassing if you do that to somebody. You lose cool points. I've never seen it happen. I've never seen the sequel of it. I've seen people jump 20 points in one day and nothing was wrong. So I'm hoping that the lab was bad the first time through. But I've never seen it actually happen. All right, so either you have a water deficit or sodium excess. So water deficit, again, if you're dumping all this out, taking diuretic, you're outside working in this damn state, you're just dripping, gets in your eyes and runs up your nose. In Arizona, it doesn't do that, it just evaporates. So anyway, losing water, not counting for it. Excess sodium is that somebody's taking sodium. Stop eating so much salt, right? All right, what's the difference between diabetes insipidus and nephrogenic diabetes insipidus? What's that?
Such a one is you don't make the hormone, and nephrogenic is
It doesn't do anything, yep. So defective end organ response to ADH, and then also central, meaning that you probably had a severe head injury and you've sheared off that pituitary thingy that hangs down from your brain. Again, here we go, anoxia, meningitis, nephrogenic. This guy, anybody use this yet lately? Amphotericin? We had that lady we had one that was growing fungus. They threw it on her. But yeah, that is like amphoterrible is what it's called. It rips out kidneys, so if you're going to go to that one, got to make sure you're going to want to use it. All right, hypernatremia. Looks a lot like hyponatremia, huh? But you can cause coma, seizures. What do we do? So it's free water replacement, right? So you need to give them water. So if you're going to get through an IV, you always have to use something other than just putting water in there. So they have to use half normal saline. If there's nothing else going on, you can give them D5 normal or D5 no sodium at all. And if you have a sodium excess, you can diurese or give that D5. And again, don't change it. Greater than 20 on this one. The other one's worse. So if you're bringing it up, you can cause brain swelling. If you're bringing it down, you can cause the opposite effect. We can actually dehydrate the brain, which is what we do anyway. So when you have a head bonk, so figure that one out. It sounds like a paper. All right. So when you're thinking about a total body water deficit, so what you have to do is figure out, why do we care? And we care because if you're not adequately replacing fluid or you're giving them too much, then you want to know where you're going to be. And when you get to be hypovolemic, hypernatremic and you want to drop that sodium down, you have to know how much water to give them, because the amount of water that you have to give them is pretty significant. And if you have an NG tube, then you can just calculate free water coming out of the tap down the NG tube, and then you're done. If you need to do it for IV fluid, you have to figure it out. And it's going to run multiple hours. You're going to put them significantly volume up if you let them get caught behind. The problem with using IV fluid is that it leaks out into the interstitium, goes in third spaces, and so it doesn't really stay in. So you got like a third after an hour worth of, if you give a liter of saline, trauma bay, an hour later there's a third of that volume still left in the vascular. The rest is all dumped out. Hence why we hate using it when we're trying to get a patient up to the operating room, give them blood, keep the water inside. All right, I'm sure this is on the in-service. Are they still doing this stuff? I think they asked me about this question on my critical care boards, and I'm like, yeah, okay, whatever. I'll give that question up. Key points. What causes the water exit is not sodium, okay? It's usually not the electrolyte. It's going to be the water balance that's going back and forth. Alteration of sodium concentration. Primary effects, CNS function. Kind of discussed that. Potassium. Here's the down and dirty on potassium. What's the down and dirty on potassium, Dr. Savoy? I'd ask Francesca, but she's busy again. Okay. Yeah. Why is potassium important? Heart rate, right? Higher blood goes in and out through this thing called a heart with 4 chambers. And so have you ever seen anybody who's hyperkalemic? Their heart goes from that nice PQRS and it starts doing this. And eventually, if you pull a sine wave out flat enough, it turns into a flat line. That's calculus. So if you see hypernatremia, you will see that's what happens, that they'll actually go into a sine wave. They start to get spread out their QRS, and eventually it'll get so long that I'm sure there's a logarithmic function that you can figure out what the actual peak to that curve is, but nerds, I'm not doing it. So it's super important for maintenance of all that, but the big thing we worry about is adjusting this. The first thing we think of when hyperkalemia happens is heart problems. And so if you boil it down to that, if you're on the ward and you're looking at patients, hyperkalemia is a bad thing. That's not something to write in the chart and move on. That's something to go, I need to fix this now. And then, Dr. Kim, how do you fix it? I can't hear you.
You give them calcium first, then and then you inject the potassium first. Insulin, even
Yes. So, in a very strong, powerful voice, what does calcium do for the cardiac? Yes. All right, and how does the potassium get into the cells by use of D50 and insulin? What's that?
Insulin causes potassium to go back into the
That is
cell.
right. It's just an exchange pump. So you put it back, you shove it back in. And so what if it's long-term hyperkalemia? Now they're like 7 or 8. KX late, how do you give that? Orally or rectally if you need to get it down now. Bind up that potassium. So, all this is all good and well, and you need to know all these things that go with it. And when you get down into the critical care aspect of it, all this is very important to how we maintain what's going on and what we think about when we're taking care of them in the ICU. But your big concerns, hyper and hypo. Hypokalemia does what?
Breathing issues.
Yeah. You start it's that whole thing that goes along with it. So you need the worst one is hyper, right? What's the highest potassium anybody's seen? Not in a renal dialysis patient. 6.7. Okay. That's 7.8. And I was ripping out his dead bowel at that time. He didn't do well. Okay. So increased renal loss, extra renal loss, and transcellular shift. Again, if you're giving them a heavy dose of insulin, you can drive it in. Usually you're going to see it with malnutrition if you're hypokalemic. Look for that alcoholism. We underappreciate the amount of withdrawal that happens in the United States. So I always look at everybody as somebody that's coming in potentially to go into withdrawal. Again, if you've injured the kidneys or you're knocking them out with a diuretic, you can lose that potassium. And what is that one that we use every day that does that? What is it? Lasix, right? So if you're giving somebody Lasix because you think they're in CHF, because that's the only reason you should give Lasix while you're a surgeon, and you didn't look and make sure the potassium wasn't greater than 4, then you were wrong. All right, because now you're going to drive that potassium way down, and you'll have problems. All right. So what do we see with hypoarrhythmias, ST depression, T-wave version? Basically get weakness and ileus. So we see it most likely coming off the medicine ward, where a lady who's been transferred from the nursing home, large dilated colon, we call it Oglesby's. First thing we tell them is adequately resuscitate the patient, correct all the electrolytes. Her potassium is 2.8. Why don't you go ahead and make sure we have the potassium in the colon to make those little nerve endings do what they're supposed to do, and they cause it to work. Okay, treat the underlying disease process. Always the source control of everything here is always try to get down to what you're trying to do. Again, diuretic, if it's happening, stop it, choose something else that's a potassium sparing. Remember that you have cofactors that go with potassium. Magnesium is one of those. You'll never get potassium up, don't give magnesium. And then correct your alkalosis. Yeah, okay. So how much is the biggest you should give a dose of potassium? What's that?
You can do 60, but go through central line.
Okay.
But do peripheral, right, 40 and 250 cc.
So what's the big concern of hanging too much potassium at one time? What? Okay, no. You can kill them dead. So this is the situation. You're in the ICU, your patient's going to crap. Somebody says, bolus that fluid in. They grab that and they shove in 60 milliequivalents of potassium. Hopefully it's going to be okay. Do you know how you kill animals in a research lab? Take potassium and inject it into their heart. So that's why that they are very strict about how much potassium they'll mix into a bag. And usually you have to order 30, 30, 30. And each one of those bags go up separate and they're marked. And then just to get your 60 or 60K run in or whatever it is. But that's the big thing is you can totally whack your patients. All right, hyperkalemia. With pseudohypokalemia, okay. Is that bad? That's bad. All right, so you can actually get potassium that comes out of the clot. Anybody seen that? I haven't seen that either. Hemolysis of the sample. So the first thing, if you see hyperkalemia, look at your patient, go look at the monitor. If they're on a monitor, make sure they're not actively having a heart attack, they're not dying, and then send them off to the lab to be repeated. Get an amp of calcium gluconate, tell your nurse that we need to give it, and then start down the road to treating the hyperkalemia until you get that lab back, if you think that lab is erroneous. The most common one is somebody will draw this blood draw over top of an IV, meaning it's being diluted by the sodium that's down uprange from it. So if they do that, you're going to have an erroneous thing. So you got to be careful jumping on that first lab. Now, if they've been low, 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 and you did something crazy like give them a loop diuretic, and they wasted that potassium overnight, now they're super low, then it's probably right. We should probably take care of that. Controversially, if you're supposed to be having a dialysis and now you're coming up on that dialysis, you may see that patient go up to 7. And that may be okay. They may be used to it. Everything that we normally give to people or do to people, TPN, we can mess that up. We can put them into renal failure. They're going to get hyperkalemic. Acidemia causes it. We have to deal with this part. And rhabdomyolysis is something that we talk about a lot. You rarely see any complications from it. But from that crush injury, meaning somebody got a truck that fell on them, you have to worry about the myoglobin go through the kidneys, which then knocks off the kidneys, and then you're dealing with renal failure in the face of a resuscitation. Burns are the worst because then if they injure the muscle and it dumps in the kidneys, you really need those kidneys to do stuff for you, and the kidneys aren't doing stuff. It's a bad day. Adrenal insufficiency, anybody ever seen that? It's usually somebody who's on chronic steroids. They come into surgery, they come out of the operating room, they're not doing well, they're hypotensive. You put on the first pressor and it doesn't work. You put on the second pressor, it doesn't work. Then you're reaching for the third and you go, oh wait, I think I should think about adrenal insufficiency now. And so you give them steroids because it's called steroid responsive hypotension. And because it helps globally cause vasoconstriction, etc., if you don't add it, you will never get them not hypotensive. And then you're totally using Levophed to crush down on that brand new anastomosis that you just put together inside their abdomen, and then they leak, and then you're down this trail of tears, as we used to call it. All right, this is where we get bad. We just talked about that. What do you do? Stop decay. Again, most of the stuff that go with this is our fault. We're not paying attention. Calcium chloride, that it stabilizes the cardiac membrane, and then redistribute. So this should be like in your handbook of how to be an intern 101, where if you come across this problem, the first thing you do is say, I have a problem. The second thing you do is you call your boss and make it their problem. And when they say, it sounds like you have a problem, you're trying to make it my problem, you say, yes, I am. This is what I'm doing. And they'll go, okay. All right, get rid of it by excretion. Go ahead and put in that resin. All that K-oxalate is a binding resin for potassium. It grabs a hold of it. And then what's the last one is hemodialysis. So if they're already a hemodialysis patient and you're having cardiac instability, ooh, that's going to be a tough one. Maybe you can put them on CRRT. Okay, extreme elevation in concentration in a patient who's not looking like they're dying is usually hemolysis or a lab error. So repeat the lab. But again, I would call somebody and say, this is what's happening. This is what they look like. I'm repeating the lab. And the only reason I say it is because I've done it long enough now that I just go, good gravy. It's got to be a lab abnormality. And usually they're all either really high, like everything across the board, or they're all really low, all across the board. And you go, well, somebody either hemolyzed or they drew it over an IV. And again, this is the thing you worry about. So for sodium, it's brain, and for potassium, it's heart. All right. That's the down and dirty of the most dry subject you're going to have all year.
There is a oral board scenario in which you mentioned they ask about a patient post-op with wound dehiscence and abdominal wall muscle necrosis. So patient has to go to the OR, but the key is you have to check the labs, and then they will give you hyperkalemia. As Dr. Wertin said, that's emergent scenario. You have to do a short-run dialysis to excrete the potassium, and then go to the OR for source control. Because if you start doing these other stuff, they don't get rid of potassium, as Dr. Wertin mentioned. So that's the catch in that scenario. So you say this is an emergent procedure, but I can't go with this potassium because the patient will code on the table when they intubate. So you're getting the scenario. It's a floor patient who has dehiscence and has muscle. This is a classic oral board scenario. And then if you go that path, the patient will code in the OR. But the word is the CRRT, the short run, quick dialysis. You do it and then go to the OR.
So I was asked that question when I was a resident still, and Dr. Cancelata put it into a motorcyclist with a traumatic crush injury, vehicle related, and he goes, and you're going to do what? Well, I'm going to take him to the operating room. And he goes, yeah, they intubate him and he dies. All right, what do you want to do really? And you go, I'm going to look at the potassium so that when I hit him with succinylcholine, they'll totally demarginate the rest of their potassium and kill that patient.
This was asked to Katie Whitlock and Michael and myself in a different scenario. This is very commonly tested. They're looking for your thought process that you have hyperkalemia, you have a source control issue, right? So how are you going to handle it? So just be mindful of that.
Awesome. Any questions? And
never is. Wish there was something cool.